Hi everyone, welcome to Medicine for Dummies. I'm Dr. V. Today we are discussing a brand new topic, acute fever. Of course, don't forget to like, subscribe, and share, and comment below if you want any other topic covered. So, let's begin. Acute fever in children is a very common presentation in wards. The possibilities are endless, and taking a thorough history, conducting a proper examination, and carrying out selective targeted investigations will help us to arrive at a diagnosis. In this video, we will be discussing how exactly to do all three of those things. We won't be talking about a specific disease per se in this video, but you can go through many of the diseases in my upcoming video series on medical disorders, where we will be talking about dengue fever and typhus and many more diseases that can cause acute fever. Let's start from the history. As always, we start with the presenting complaint. In a case such as this, the presentation would be fever for a short duration. Then we move on to the history of the presenting complaint, where we describe the fever. We need to ask when the fever started, how long the fever lasted, and the type of fever. There are many types of fever, as you can see in this table, and depending on the type of fever, we may be able to get some idea about the disease. Then we ask about the peak temperature and what the patient feels in between the fever spikes. That is, if the patient is feeling well in between, or is the patient persistently ill. We also need to ask whether the patient responds to simple antipyretics like paracetamol, whether chills, rigors, and night sweats were present, and any other associated features. The next step, as I always say, is to exclude the differential diagnoses. As I said before, there are hundreds of causes for fever, and only few are given here. We have to exclude meningitis by asking if the patient complained of any headache and photophobia, which is light sensitivity and eye discomfort in bright light, and phonophobia, which is an aversion to loud sounds. These are both caused by meningeal irritation. Then we can ask if the child had any dysuria, if the child is older, or frequency that could suggest a urinary tract infection. Upper respiratory tract infections will be evident with nasal congestion and rhinorrhea, and a lower respiratory tract infection will cause cough and sputum production, which may or may not be purulent. You can check for pharyngitis by asking for a history of sore throat, and ear infection by inquiring about ear discharge or earache from an older child. Sinusitis, which is a common accompaniment of upper respiratory tract infections, can cause headache and periorbital pain, but may be difficult to elicit from history from a very young child. Leptospirosis is seen commonly where there is mud exposure of the child, where rat urine infected with the bacteria is seen in mud, and when children play in the mud, the bacteria can enter the body through small wounds in the legs. Acute gastroenteritis, which we talked about in detail, is also a cause for fever, and you may see associated diarrhea and vomiting. Acute hepatitis, especially A and E, that are transmitted through the fecal-oral route and associated with poor hygiene, needs to be excluded by asking about yellowish discoloration of eyes and right hypochondriac pain. We can ask about any wounds that might be infected as well. A common tropical illness seen in the rainy season is dengue fever, which is mosquito-borne, so ask about any contact history where any siblings or neighbors have had the disease, and any associated joint and muscle pains. The hallmark of infectious mononucleosis or kissing disease, which is common in preschool-age children, is lymphadenopathy. Typhoid fever is associated with poor hygiene and eating from outside, and typhus fever, which is either louse-borne or flea-borne, will present with a rash. Also, consider other diseases according to associated features like Kawasaki disease. Finish off the history of the presenting complaint by asking about the risk factors and complications. According to the most possible diagnosis, risk factors can vary, but ask about any contact history of the disease, travel history to endemic areas or where the suspected illness is common, and about environmental cleanliness and surrounding mosquito breeding sites. Complications also depend on the likely diagnosis, but some common ones to any infection can be bleeding manifestations in severe sepsis or dengue fever, hemorrhagic fever as seen in dengue, septic shock, and encephalitis, which can present with seizures. Finish off the other components of the history, such as the past medical history, past surgical history, birth, growth, development, immunization, dietary, allergic, drug, and family history. Since this is an acute event, these components won't be that relevant, so mention only briefly. You can elaborate on the social history, as a lot of conditions associated with hygiene and environmental cleanliness can cause acute fever. Once the history is completed, move on to the examination. As always, start from the growth parameters and plot them in graphs. Look at the general appearance, whether the patient looks ill or well. If the patient is having a fever, try to measure it. Check to see if the patient is pale by looking at the conjunctiva and if the patient has jaundice or yellowish discoloration of the eyes. You can check for lymphadenopathy, especially in the cervical region, and throat examination may show evidence of a sore throat or pustules. Carefully looking at the ears for pus discharge and an otoscopic examination may be necessary, and look for any rashes that may be seen in meningitis, typhus, and other conditions. Neck stiffness, Brudzinski sign, and Koenig sign are all features of meningism, and you can elicit these by these maneuvers seen here. Check for complications by looking for features of shock. You can assess capillary refill time as seen here and look for cold peripheries, a cold line, and low blood pressure. Keep in mind that cold peripheries only occur in late stages of shock, as initially sepsis causes vasodilatation, which will result in warm erythematous peripheries. Also check for wound infections, where small wounds, not very evident, may be causing the fever. Complete the examination by looking for abdominal tenderness and hepatomegaly in the abdominal examination, which may indicate complicated dengue fever and hepatitis. Respiratory system examination may show features of consolidation, where you might hear coarse crackles, or parapneumonic effusion. CNS examination is necessary to assess neurological deficits and features of raised intracranial pressure. And finish off with the CVS examination, where you look for features of shock. The last step is to investigate the patient, which will confirm the diagnosis or exclude some possibilities. This is not an exhaustive list, and we don't do each and every one of these always, but this is just a rough guide given here. We can do simple things like a urine full report and a urine culture to look for a urinary tract infection, and a full blood count, which will give an idea whether this could be a bacterial infection or viral infection, and whether the platelets are low as seen with dengue fever. The hematocrit, which will be rising if the dengue is progressing to the leaking phase, and many more valuable information can be gained by a full blood count. We can do NS1 antigen, which is done to diagnose dengue fever. If the presentation is delayed, we may need to do dengue IgM and IgG. We can also do acute phase reactants, CRP and ESR, which will be elevated in acute infections, and a chest x-ray, which will show pneumonic patches. If there are any wounds, we can take swabs, and if there is a throat infection, we may take a throat swab. We can do a lumbar puncture, but only if strictly necessary, and the history is indicative of meningitis, as it is a very invasive procedure. We can also do leptospira antibodies to detect leptospirosis and any other investigations depending on other suspected infection like rickettsia antibodies or X-ray sinus flu. So that is how to take a history from a patient with acute fever and how to examine and investigate in a directed way. To learn more about different diseases causing acute fever in the list we considered, refer my upcoming videos. Thanks for watching!